Good afternoon and welcome to our October seminar as part of the PRCHN seminar series. Before we get started, just a few logistics and housekeeping for today's seminar. Please use the Q&A feature to type in questions. Also, there is a raise your hand feature which you can use during the question and answer period after the presentation if you would like to request your microphone to be unmuted. We're excited to have Rita Horwitz present on the Better Health Pathways Community Hub today. Rita Horwitz is the president and CEO of Better Health Partnership, a regional health improvement collaborative located in Northeast Ohio that brings healthcare, social services, employers, payers, and other stakeholders together to share best practices and accelerate data-informed improvements in equitable population and community health. A graduate of The Ohio State University School of Nursing and Case Western Reserve University's Healthcare Executive Management Program, she has held leadership positions in ambulatory healthcare, corporate-based health and wellness, business development, and regional health collaboration. She serves on the board of directors of the Network for Regional Healthcare Improvement, United Way's Community Advisory Board, and various other leadership forums. In 2018, she received recognition in Crain's Cleveland Business as one of Northeast Ohio's most notable women in healthcare and is a graduate of Leadership Cleveland's class of 2019. I'd like to welcome Rita Horwitz today.
Thank you, Sarah, and hello, everybody. It's great to be here. Completely appreciate the opportunity to share more information about the new Better Health Pathways Hub for Cuyahoga County. In today's session, I'm going to give you a little bit of background about, of course, what is a hub, and then how did it come to be in Cuyahoga County? What's the background on that? A little bit about how the model itself actually works. We'll take a look at some strategic partnerships that we've formed in the hub, specifically targeting populations that are complex and challenging. We have some early data, very early data and results that we're happy to share with you. And we'll talk about some future strategies, kind of what's on deck and coming, we hope in 2021 for the hub model. So next slide, please. So as Sarah mentioned, Better Health Partnership, just for those of you who don't know who we are, we have been a collaborative of multi-stakeholders since 2007, working together, and we're all about collectively improving health and reducing health disparities in the region so that, you know, we work with health, clinical providers and social services and employers and payers and public health and government and schools and lots of community organizations. So I'm sure you see some familiar faces in this slide as well. Next slide, please. So again, our vision is to make sure and to see that Northeast Ohio is one of the healthiest places to live and the best places to do business. And we're all about bringing people together. This is back in the day when COVID wasn't in the way. And as you see, we bring lots of people together at least 2-3 times a year to really celebrate our successes as a collaborative and share best practices to help continue to advance improvements in the community. Next slide, please. So in our portfolio of health improvement work, starting on the left-hand side, you can see we start with infant and maternal health that we work on with our partners. That work began in 2018 when we started working very closely with First Year Cleveland. And then in 2016, we worked on children's health. We brought them into the picture, working on obesity and asthma, and more recently, mental behavioral health and children at risk for lead exposure. And adult health has been with us from the beginning, 2007 to present, where we've worked on and continue to work on hypertension, diabetes, colorectal cancer screening, and more recently, COVID testing and prevention for minority populations in our community. And you'll notice that the Pathways Hub there is shown that it is actually enabling and supporting all of those initiatives in various ways that I'll share more about today in today's webinar. Next slide, please. So what is a Pathways Community Hub? I'm sure some of you are wondering what that might be. Next slide. So a Pathways Community Hub is a centralized care coordination model for at-risk populations. It includes targeting pregnant women, infants, children, and adults. It's evidence-based. It's been documented to improve health, reduce costs, and promote equity. It leverages community health workers who are employed by care coordination agencies to navigate pathways for hub clients. And we'll get more into what those pathways are in a little bit. The hubs are certified by the Pathways Community Hub Institute, which is a national organization. And actually, Better Health we just applied for certification. We're going through our site review this Friday. So hopefully by the end of the year, we have an official certified Pathways Hub. Next slide, please. These are some of the model endorsers and supporters. The Ohio Commission on Minority Health is a huge supporter. In fact, primarily responsible why there are so many hubs in Ohio doing so well. We have to thank Director Angie Dawson for that. And the Ohio Department of Medicaid, the model is actually reimbursed by managed care. And we have many, many other well-known supporters at the state and national levels. It's also been designated as a best practice by the Association of Maternal and Child Health Programs. Next slide, please. So in Ohio, we actually have 10 hubs. Cuyahoga County was a little bit late to the party, but nevertheless, we have joined the mix of hubs. There's actually about 35 plus hubs nationwide. As you can see in the future, there are still some areas that are on the radar from the Commission on Minority Health to hopefully get hubs in Lorain, Southeast Ohio, and Warren. The founders of the hub are Dr. Mark and Sarah Redding. Some of you may know them, and they have established and run the Mansfield Hub for years. They're actually now have moved on to be part of the Pathways Community Hub Institute. So the organization that certifies hubs, that's where their main focus is right now, to help all of them. They actually got their start in Alaska when they started helping pregnant women with their babies and addressed infant mortality there, and had such success with the model that they brought it back here to Mansfield and started it from the ground up. There's great documentation on the success of the Mansfield hub, and again, I think it's pretty impressive to see that their model took hold and went across the nation. Next slide, please. So what the hub allows us to do is really, because it's a scalable model, you can really get a lot of scale to this centralized care coordination model. It allows us to start really moving upstream to have much greater impact on health than we can otherwise working in silos and not in standardized ways. The hub uses some centralized data. So again, that data informs a lot of the strategies, the work, the outcomes that the community health workers might be achieving. They certainly can work, the community health workers work on that downstream 20% influence on health with clinical care providers. There's a lot of care coordination between primary care or other healthcare providers and community health workers. But then they also work on the 80%, which is the main focus of the model, which are all the social determinants of health. And so they do help individuals and families in that midstream individual impact space. And yet they also have the ability, because there's so much rich data that comes from the hubs, that we can use that information for more to inform policy and advocacy as well. Examples of that would be things that we can help inform Lead Safe Cleveland Coalition, First Year Cleveland, and as you may know, Director Dawson is always advocating the hub model there in Columbus. Next slide, please. So how did a hub come to be in Cuyahoga County? Next slide, please. So back in July of 2018, Bernie Kerrigan, as Executive Director of First Year Cleveland and the First Year Cleveland Executive Committee, brought the stakeholders of the community together, those that were involved in First Year Cleveland and others, to talk about responding to what was going to be the RFP from the Ohio Commission on Minority Health. Again, Cuyahoga County was high on the radar for the commission. There was a lot of encouragement, especially given the successes that the hub has proven in infant mortality, that it was only natural that First Year Cleveland would have a high interest in seeing that Cuyahoga County did get a hub. Next slide, please. And part of the reason why the hub was advocated for is that it provides a means of future sustainable funding for some of the current existing home visiting programs of First Year Cleveland, which are grant funded. So as grants go away, the hub model, again, is an infrastructure that's built, that's meant to be long-term, that has scale to it, and that contracts with managed care to help bring revenue to those care coordination agencies who partner with the hub. And as mentioned before, the data sharing is rich and can be leveraged to inform policy and advocacy. So there was some strong support from the First Year Cleveland stakeholders that someone should step up in Cuyahoga County to be a lead agency and make the application, respond to that RFP from the commission. Next slide, please. So with a little nudging from them to us, to Better Health Partnership, we did decide to look into this more about being a lead agency, and thank you so much to Elaine Borowski and Case Western and her team for providing us with some CTSC funding to move forward with doing our discovery phase and design phase of the hub, so that I could put something in front of our board of directors to say and make a decision, are we going for this? Are we going to be the lead agency and make an application or not? And that just proved to be very beneficial. So again, thank you for that. We were able to put a business plan together with that funding. We were able to secure a technical assistance from the well-established Toledo Hub. And we were able to get a lot of folks on board through different convenings and get some memorandums of understandings put together. We made the application to the commission in the months of May and June. We started rapidly doing some local fundraising to get the hub up and going. We established an independent evaluator that the commission requires, and a community advisory board also required for hubs. And by the end of the year, we were notified that we had received the award, and we had 90 days to get the hub up and going, including contracting with managed care to get reimbursement. So a very busy 2019 for Better Health. Next slide, please. And we were able to secure, we're happy to say, all of these folks have been funding the hub, are funding the hub to get us going, to get us started. Again, thank you to Case Western and First Year Cleveland. Again, without your support, this likely would not have happened. Next slide, please. And so in 2020, we launched the hub. We began in January getting the operational arm put in place. In February, this was our very first cohort of community health workers and their supervisors from the agencies who signed up with us. Obviously, this was just pre-COVID, as we are all together and no masks. And everybody had a great time being trained in the model. Since then, you can see the list of agencies and who has partnered with the hub so far. So we're up to 10 agencies now and about 25 plus community health workers. And they stem from quite a variety, because the model does have a lot of versatility to it in terms of the types of populations that can be served. Next slide, please. Our managed care partners that we did get contracts established with was United Healthcare, Buckeye Health Plan, and CareSource. And it might be interesting for you to know that in Senate Bill 332, which I think came out in 2015, it was a requirement that managed care actually partner and reimburse hubs for outcomes. And in the current Medicaid request for applications that's going on now for reprocurement, again, a lot of strong connections between what's required of managed care organizations and pathway hubs that are certified. And we see future opportunities with other funders such as employers, additional Medicaid health plans, commercial health plans, and maybe someday Medicare, because a lot of seniors need this help as well. Next slide, please. We've established a community advisory board. We had one meeting in 2020, and the next meeting is slotted for December. These are the folks from the community that also include some of our hub partners and our clients of the hub, our community health workers and other stakeholders. They really hold us to model integrity and accountability. That's their job. They make sure we use a continuous quality improvement process for our services. And ultimately will be a group that will be able to help advocate for some of the social determinant of health upstream interventions that the hub can hopefully help build the case for through its rich data. Next slide, please. So some of you might be wondering, well, how does this model exactly work? So a couple slides on this. Next slide, please. So you might see here that the hub is right in the middle, which is where we're supposed to be. We are the entity that takes in referrals, client referrals that might come from the community, that might come from a health system, that might come from managed care, community health workers, schools, any other kinds of sources where they identify people in need. That's pregnant moms, adults, children, anybody who's got some health and or social kinds of needs. Those referrals come to the hub. The hub team triages those referrals and then sends them to a care coordinating agency that's partnered with the hub. So that's one of those 10 that you would have seen listed before. And the care coordinating agency then, who employs the community health workers, enroll those clients. They do some needs assessment of the clients, and based on those needs, they will open certain pathways, and then they will work to close those pathways for the client to help them meet their goals. When that happens, the hub reviews all of that documentation, makes sure everything was followed according to the right protocols and everything is validated. And when that's done, then the hub will actually invoice Medicaid managed care, the ones that we're partnered with, for reimbursement, for payment for those care coordination agencies. And then we keep a small administrative fee, and the care coordination agency gets paid for the pathways that were closed and the outcomes that they achieved. We also provide, the hub also provides monthly meetings with the community health workers for professional development, best practice sharing. We meet with other hubs across Ohio for that same reason. And we do a lot of evaluation and reporting, of course, to the community and to our stakeholders. And we also lead the community advisory board meetings. The managed care organizations also refer to the hub, I should note. There's a lot of folks of their members who need help, and they will often send us 50, 60 people a month, lists of people that they have that they know are in the community and need our assistance. Next slide, please. So basically the job of the community health worker is to find their client, do an assessment, help get them care coordination and treatment by connecting them in the 20 pathways. And then we measure outcomes through a data system, care coordination system. It's a standardized data system that everyone uses. And there's an independent evaluator that looks at all of that data and makes sure that we are reporting things accurately. Next slide, please. So these are the 20 evidence-based pathways you see here. If some of you that are in the social service field or other kinds of home visiting programs and such, you look at this list and you say, well, this is what we do. And that's true. There's nothing here that's probably not unfamiliar to many people working in helping and assisting at-risk populations. One of the differences is, next slide please, that these pathways are sort of broken down and the outcomes are what make this model unique. This is a value-based, outcome-based model that has reimbursement attached to it. So it's not enough for community health workers to simply refer or give a warm handoff, or as you know, many people know, in a doctor's office, you get a referral, a prescription, and there you go on your way and you're on your own. This is the community health worker really making sure that pathways are closed, that goals are met, that outcomes are achieved. So in things where you see behavioral health, it's not just a behavioral health referral if depression might have been flagged, but it's that client has kept 3 scheduled appointments for behavioral health issues before we can submit for payment and reimbursement to a managed care organization. And that's really the design of the model, is to be more in that value-based, outcome-based space. Same thing with housing. Clients need to be in a home, so housing secured and in it for 30 days. Next slide, please. And here again, similar patterns. You know, immunizations, got to be able to prove that those immunizations are up to date. We will have for pregnancy, the pregnancy pathway is considered closed, and it's actually, there's a tiered payment and reimbursement based on the weight of the baby, the health of the baby. So we're really looking to confirm that the clients have delivered a healthy baby that weighs more than 5 pounds, 8 ounces. Tobacco cessation is in here as well. And again, showing and documenting that the client has actually stopped using tobacco for a minimum of 30 days. So you get a sense of how the model works. And all of this is tracked in this data system and validated by the hub. Next slide, please. So somewhat unexpectedly, we had some emerging new partnerships early on with us just establishing the hub that I wanted to share with you, because I think it's really an indicator of what more we can do, and again, how applicable this model is to various populations and situations. So the 3 areas that we're strategically partnered in and targeting are infant mortality, lead exposure in children, and homeless adults that are high ED utilizers. Next slide, please. So again, the hub having its well-established track record in infant mortality, we are very, very closely tied to First Year Cleveland with the hub model. And as you know, as many know, there were about close to 14,000 babies born in 2019. 120 of those never saw their first birthday, and 73% of those babies were African Americans from all socioeconomic levels. So the hub becomes a resource for these families, for these pregnant moms, to work with a community health worker to A, try to deliver a healthy weight baby, and then B, work with that mom and that infant, you know, on things like safe sleep and nutrition and all kinds of things in that first year of life. Next slide, please. I've mentioned that the hub is a proven model with infant mortality. Here's just a study that Buckeye Health Plan did, and it was published in, I believe, Health Affairs in 2018. And they looked at the Northwest Ohio Pathways Hub, the Toledo Hub, and looked at infant mortality rates for the same years for those moms in the hub, and then compared it to the Lucas County infant mortality rate, and you can see what a difference, especially in the African American Black population, almost twice the rate in Lucas County for infant mortality than those moms that used the Pathways Hub. And it was also learned that the high-risk mothers who did not use the hub interventions were about 1.5 times more likely to deliver a baby who needed special care or NICU care than those who were in the hub intervention. And I don't need to tell you how expensive NICU can get and how stressful that can be. So again, pretty well documented in infant mortality. Where we're less documented and proven is in children or adults with chronic disease, but believe me, it is front and center on our radar, all the hub's radars. Now that the hubs have moved into that space, that we will use the data to try and capture similar successes. Next slide, please. So interestingly, LeadSafe Cleveland Coalition is leveraging the hub as well as the Better Health Partnership just quality improvement model. So an example of how our existing Regional Health Improvement Collaborative works and our hub work together. We are working with these partners at Rainbow Babies and Children's, Metro Health, Neighborhood Family Practice, and Care Alliance on the clinical side to look at what providers and practices are ordering lead tests for children at risk for lead exposure, and are they getting them done? For those where there are gaps, not getting them done, the hub steps in, and the community health workers will hopefully work with those families to get those children tested. And for those that test positive, we will get them connected to Bright Beginnings and Best in Children for early intervention. Next slide, please. And for those of you just not as familiar with what is happening with children with lead exposure, there's really quite a gap in terms of who needs to be tested and how many are getting tested. So there's about 25% of incoming kindergartners into the Cleveland Municipal School District that have elevated blood levels. And we know that even though Medicaid requires and mandates testing, we still have some pretty big gaps. So ages 1 and 2, only about 50% are getting tested, and by age 2, about 34%. So we have some opportunity here. Next slide, please. And so as mentioned, how will we help? Well, our clinical practices will help us identify children from the medical records, from the EMR, who aren't getting tested. We will connect them to our agencies and community health workers to work with those families, and certainly we will get them connected to help when there's elevated lead levels. Next slide, please. So another opportunity that came our way when the hub got established was from the Cleveland Clinic, where there's a lot of work being done there through some grant work of theirs on the homeless, high utilizing population of their emergency rooms and their inpatient psychiatry. So they approached us about potentially being able to leverage the hub model to see if we could make some impact. Next slide, please. And I think you have to hit the button again. It's one of those animated ones. There you go. So this was rather sobering when I saw this, and Dr. Jeremy Wella from the Cleveland Clinic put this together and really shows that, you know, the life expectancy for homeless people, there's about 30 years difference compared to the average person, and really does show us that despite all the improvements in health and health care, it really has not had an impact on this population. Next slide, please. And you can go again. And then this slide is showing that, if you go look at the very left-hand bar graph there, that the homeless population, the green bar, you know, the utilization of the emergency room, they're using at about 40% encounters, which is about 5 times higher than the overall average. And they're using primary care less. So again, by connecting folks to some outside social service kinds of help, getting people housing, helping them with their social needs, can we reduce that ED utilization? As I understand it, a lot of those folks come into the EDs, you know, not so much because they're sick, but because they're hungry or they need a place to sleep. So, so we're hoping to make an impact there. Next slide, please. And so this is how we're working with the clinic. Right now, this just gotten started, and it'll be about a year long, the pilot. So we get these referrals from the Cleveland Clinic emergency department or from inpatient psych, folks they've identified as high utilizers that are homeless. And we enroll them in the hub, and we work with primarily right now one of our agencies, Carmela Rose Health Foundation, who works in homeless shelters, so knows this population quite well and knows how to navigate it quite well. So between them and Cleveland Clinic, working to coordinate care for these folks, we hope to see some new outcomes. We're going to look at housing stabilization. Can we decrease emergency department use and inpatient psych? What about costs? What about other chronic conditions they might have? Can we improve health? So again, a pilot, but a very interesting one, and we're hoping to have some impact. Next slide, please. This is a case study, not under this pilot, but just an example from Carmela Rose that does navigate the homeless shelters of an individual 37-year-old pregnant homeless female here who, you know, when I see a slide that says 30-year life expectancy difference, I think what a shame that, you know, here's someone young and vibrant and who might not live as long as she possibly could if we can't get her homelessness under control. But Carmela Rose was able to get her health insurance, get her connected to primary care, get her social service needs met, make sure she saw her prenatal care doc, and she did deliver a healthy weight baby. Next slide, please. So we have some very early data. Again, I guess I want to make the point that we opened this hub when COVID hit. So we don't have a lot of numbers yet, but things are starting to pick up, and hopefully by this year, next time, we'll have a lot more data to share. Next slide, please. So as of right now, we have 148 folks enrolled in the hub. That number's changing every day. And although we don't have a lot, at least the curve is going in the right direction. Next slide, please. These are the zip codes where the clients, how many clients are seen in these different zip codes. Again, this is somewhat dependent on which care coordination agencies and community health workers have been able to work during COVID. Many of them were, many community health workers were furloughed during that time. As you know, the governor, or may not know, the governor actually shut down face-to-face home visiting. So it made it difficult for people not experienced in the hub model to get started and to find clients and to meet with them and try to even establish a relationship. It was really just lousy timing from that standpoint. But Carmela Rose, which is a well-established care coordination agency, they had worked with the Mansfield Hub before. So fortunately, they were able to enroll a lot of these adult clients that were homeless and to keep their work going virtually because they'd already had some established relationships. Next slide, please. So these are some of the numbers and the types of the pathways and the status of those. For those 148 clients, we've had actually over 700 pathways opened. You can see the top bar that's in the social service area, no surprise there. The red means that the pathway is still open, that they're working on it. The darker blue is that the pathways were opened and closed. And then the lighter blue is the pathway was finished, but finished incomplete. They weren't able to meet that final goal. So let's say it was behavioral health and they only kept 2 appointments and not 3. And maybe that client is no longer working with the community health worker. That would be an example of a finished and complete. The top social service needs were food, finance, and housing, not too surprising. Medical referrals were also quite large, and medical homes. So a lot of these people need connection to clinical care. Education, the model does use a lot of education. We have a resource built right into the data system, and we're always looking for new new resources to be added to that. So feel free to send us information about things that we can share with our clients. And obviously pregnancy and health insurance are also some of the ones that flagged out in this data. Next slide, please. So our clients, at least the profile right now of the ones that are in there, and again, remember this was kind of skewed for a lot of homeless population. So no surprise we see significant amount in the adult and pregnant populations having an income of $0 to $5,000 annually, which is very sad. And 83% of our enrolled clients are unemployed. Next slide, please. Other profile that we saw in the data so far, quite a few, 63% have an underlying chronic health condition. 55% have recently been to prison. 53% feel stressed, no doubt, with 83% unemployed and living in poverty. 20% have moderate to severe levels of depression, and 40% have at least one ED visit in the past year, which was interesting that kind of correlated with what we saw in the Cleveland Clinic slide. And 12% have been to the ED three or more times. Next slide, please. So what's on deck next on our radar for the hub? Next slide. It's all about growth, expansion, sustainability. Again, this is a scalable model. This is intended to be infrastructure building for Cuyahoga County long-term. So that's the way we're going to have the most impact on at-risk populations and their needs. So it's all about expanding our community partnerships and referrals, get the hub more known in Cuyahoga County, get more referrals to the hub, build upon and continue to expand our care coordination agencies, our managed care partners, look at the commercial and employer markets. They too have folks that have social and economic and healthcare needs. And then there's an opportunities here to do more targeted strategies like you saw us doing with, let's say, Cleveland Coalition, First Year Cleveland, and the clinic. We are in conversations now with Cleveland Municipal School District, Say Yes to Education, who have family support specialists that will need some type of an off-ramp sustainability plan. So we're looking at potentially training those specialists in the hub model so they can continue to support and give the wraparound support to families that are needed. Anti-human trafficking is an area we might look at. The Toledo hub is in this space quite strongly, so we can learn from them as well. So that might be an opportunity. The Columbus hub is very active in reducing recidivism rates when people returning mainstream from jail, and they've had quite a bit of success with that. We've had some inquiry, and we'll be talking to some folks. Can we help the young adults transferring away and out of foster care into adulthood to help really stabilize their lives as they go into that next phase? And we are talking right now with the Greater Cleveland Food Bank and First Year Cleveland, more specifically about doing unique workflows and processes to make sure that pregnant moms and their families and their infants, that their food insecurity needs get addressed through the hub model. Next slide. And finally, the big aspirational thing that we must do in this community is to start to connect all these disparate data sources. I mean, the hub is great. It has a strong data system, but like any of these things, it's not right now connected to anything else. So if we really want to be successful in coordinating care across sectors for at-risk populations, we've got to get more interoperability going, not only with the hub, but with electronic medical records, with school data, with public health data, other social service agency data. And there's been progress on this front. Better Health and the Center for Health Affairs and United Way have been convening folks for a while to try and select a platform for the community. That would be great if we could all get on one platform to start building that interoperability. Metro Health went forward with their Unite Us platform, which is very strong, has a lot of capabilities. And we're actually going to do a little pilot work between the hub and other social service agencies and Unite Us to see what can be done there. And next slide, please. And so that's my message about the Better Health Pathways Hub. And I thank you for your time and listening. And I think this is the time where we start taking questions.
Thank you so much. As a reminder, if you have questions, you can type them into the Q&A box, or you can use the raise hand feature and to request your mic be unmuted. So we'll go with our first question in the Q&A box. This is, what % of population served so far are children or minors?
Yeah, so we haven't had a large amount. It's been a smaller portion so far, but when we start our lead testing work, we anticipate that's going to go up considerably. That'll be a much greater focus on that. Our managed care partners who are sending us the referrals, they have all been pregnancy referrals right now. So they will likely start to give us also some referrals for children without who need to be lead tested as well.
Okay, we have a hand raised. You should be able to unmute yourself and talk now.
Jenny, you can ask your question.
I don't have a question. I just unmuted myself.
We have another question. Amongst the homeless population, what is the prevalence of schizophrenia or other types of severe mental illness?
Yeah, actually Dr. Welliff would have that information at the clinic, but I remember him saying, I want to say it was close to maybe 40 to 50%, but don't quote me on that. There's a lot that use their inpatient psych services as well. So there's a pretty strong correlation between a lot of the homeless and those with mental health needs.
Okay, we have another hand raised. You can unmute yourself, Elaine Borowski.
Hi, Rita. It's Elaine. This is
Hi.
awesome.
Hi.
I'm sorry I came on a little late, but I'm so impressed by where this has gone just over such a short period of time. Can you tell us a little bit more? And you may have done this at the beginning, and I apologize if I missed this, but how does the hub actually integrate with the data that's collected with Better Health Partnership? Is there a full integration?
No, we do that through our data team, Elaine. There's not we collect the data, as you know, for Better Health Partnership from the electronic medical records. So we have that, and then we have the social determinant of health data from the hub. So we're manually bridging that together. But
could you follow somebody that participated in the hub through one of the practices?
we may be able to. Yeah, I think this is what we're going to try to test with Unite Us.
Yeah.
In the pilot work that we're doing. We hope to.
All right. And then I had the same follow-up question, I think, was about the mental health. I was surprised that there was such a low number of like depressive symptoms or something of 20%. It strikes me that would be higher. So
right.
Is it who you're capturing, do you think, or is it,
Could be. Yeah, it could be. Again, we have small numbers right now.
Mm-hmm.
So it could be that. And then with pregnancy, we haven't been always doing the full pregnancy depression screening either. So we're talking about that in terms of needing to do that more universally.
Thank you. Like I would just say, to me, the real value of this whole thing is the infrastructure that you're building. Like this is what we've all been talking about. Like how do you make these connections? And the infrastructure is the best, is the most important piece of that puzzle. in some ways, because then once you do that, as long as everybody's still at the table, as long as everybody sits at the table, right?
Yes.
And are all the players, do you feel like you're still bringing, or is everybody who's needs to be at the table in the process, do you think?
I think we have we can add more. There's,
Yeah.
we're learning fast what's in that social service space.
Yeah.
And so our community advisory board will continue to grow. And that'll be really good for us. And we want to get more, we want to get more at that neighborhood grassroots level.
Yes.
to really make sure we're pulling in from the community, the people they see need help. And so we recently had a talk with Central Neighborhood about that. And I think that's going to be one focus area for us that we'll be able to just get right in there and start to learn all the community agencies in that neighborhood, work with the Promise neighborhood, and St. V's, and try to get a real local boots on the ground referral pattern going.
Like you and I've talked, this will be my lesson, I'll jump off, but you and I've talked about this. One of the most important things you could probably do, though, is just to keep ensuring that the community health workers that the agencies are actually hiring are in fact from those neighborhoods.
Yes.
If you jump away from that, the whole thing could fall apart. So
yes,
but that's the most authentic thing that could happen. So that'd be my comments about that.
Yeah.
Thank you again, Rita.
That's wonderful. And Elaine, thank you again for helping us get jump started. I mentioned that early, you might have missed that. But our CTSC funding to get us going. Thank you.
Yeah. Thank you. Great.
Hi, Rita, it's Erica, and I wanted to ask a quick question.
Sure.
It's really phenomenal. I'm selfishly glad that we've been able to have you present. As I was listening, it seems like you're really identifying people who are in a lot of transition. So kids transitioning out of foster care, individuals transitioning out of prison, people transitioning into and out of homelessness. So, and I'm guessing that in this process, you're identifying ways to maybe catch those folks a little earlier, but maybe outside of the scope of what you all are doing. So how are you thinking about kind of catching folks also in those transition spaces, which would kind of, I think, be the complement to what Elaine was saying and what you were just talking about being on the ground in neighborhoods. But are those partners there, and do you feel like there's some opportunity there to do some work to catch them kind of as they're early in their transition, to pull them into this model?
Yes. Oh, absolutely. I think we need to meet with, the organizations that could partner with us, right, to give us some lead time. Let's get to start working with them before they're actually in that moment. That would be the goal. Mm-hmm. And so that we can help stabilize them and mainstream them for success. Yeah, absolutely. And part of that'll be we'll learn from our sister hubs, right? So those that have done some work in this space and are experienced in this space, we'll definitely tap them as well for their best practices.
On that, Rita, right?
Mm-hmm.
Because you mentioned the support from the state and the networks across. Do you think that there are opportunities then for thinking about, at the state level where there's better coordination? And thinking about this, making that kind of not just a bottom up, but also a top down to really get those systems thinking about how best to support people together.
Yeah, absolutely. I mean, I think the hub has lived under the, infant mortality umbrella for a long time, right? And the hubs, it's just been the past couple of years that they've realized this model can be applied for many different purposes and populations. And so I think we can't work fast enough to get some successes documented, and then yes, take that to a statewide level to really advocate to do things like this more at scale and have the support to do it.
Thanks.
Sure, thank you.
If there are any other questions, please type them into the question and answer, or you can raise your hand. there's no other questions, thank you so much, Rita Horwitz, for joining us today. I really appreciate hearing from you. And thank you everyone for joining us on this webinar. Our next seminar is going to be on November 11th with Dr. Sherry Bolin. And you can find more details in register for the seminar and see other parts of our seminar series. It's in the chat box that you can see that link. Oh, we have another question about if you're able to receive the PowerPoint. We do post our recordings live. Rita, do you have any thoughts about PowerPoint?
Oh, no, you can post it. Sure. That'd be fine.
Great, thank you.
And also just feel free to email me if you have suggestions, you know, partners out there, community organizations that you think would be interested or just want to learn more. Absolutely feel free to reach out.
Great, thank you. And if you want to reach out to me regarding the PowerPoint, my contact information was in the invite that you received for this webinar. So please feel free to reach out to me, and I can also connect you with Rita Horwitz regarding the PowerPoint.
Right.
Great, thank you all so much and have a wonderful day.
Thank you.
Thanks, Rita.
Sure.